So continue with the immune disorder. We're going to pick up here. It's a busy slide, but it is um, tell sort of like a summary of um, the uh, how the immune system play important role in related to many conditions or diseases that uh, associated the immune system and disease in our body. Okay, the one of the important thing that I want you to know from this slide, and that this is whenever you have a substance, particularly if it's foreign substance, like here, um, that foreign substance or particle, which is not part of your cell, can elicit an immune response. That's considered an antigen, right? When you get into this situation, when you get an immune response, we are referred to as adaptive immunity. Okay, we're not talking about innate immunity. We're not talking about the skin, the acid, the interferon, inflammation. All that is innate immunity. Okay, this is adaptive immunity, and adaptive immunity. Um, Important characteristic, and that is two important characteristic that is very specific, right? And there's an immunological memory that there is a if you haven't responded to this one red, cartoon drawing, in the future, whatever that you create, chemicals or cellular, those substances is very specific to that. Like we say, we're going to have an immune system toward the coronavirus. It's going to be very specific to the coronavirus. It's not going to be to influenza virus or smallpox or whatever. It's very specific. And I'm going to talk to you what we mean by immunological memory in a little bit. But again, the take-home message is that there's two, right? There's within adaptive immunity, there are two arms, if you will. There's a humoral part, which is mediated by antibody, and there's a cellular, which is mediated by T cells, right? So they're lymphocyte, but there are two different kinds of lymphocyte. There's B lymphocyte and there are T lymphocytes. So you can associate that. B lymphocyte is involved in humoral immunity, which is the liquid part, and T lymphocyte is involved in cellular immunity. And the cells that is involved in killing virus infected cells or cancer cell or cytotoxic T cell. These cells are also known as CD8 positive, right? And the cells that produces the antibody are B cells. And once they become more differentiated, then they become plasma cells. So they're, and if you want to know the marker, they're like CD19 is considered B lymphocyte. Okay. Um, and um, and we will see then that there are 5 different classes of these antibody. Not all antibody are alike. There are 5 different classes of immunoglobulins you will see. Okay, and sometimes these antibody typically will have different types of activity. They could be immunoglobulate, they could be involved in opsonization, they could be involved in antibody mediated cell toxicity, in which how you can kill the cell, but it has to through the antibody. But in some cases, the antibody can react it to your own cell. Okay, it's an antibody that comes about that reacted to your own self-antigen. Of course, this is known as autoimmune disease, and we're going to talk about more of that a little bit later. But the immunoglobulins sometimes can overreact it to something that is not atypical, for example, which means that atopy, like danders and stuff like that. So we call that hypersensitivity or allergic reaction. And there are 4 different hypersensitivity that I want you to know. uh, to note right now, you can say type 1, type 2, type 3 are mediated by antibodies. And then the fourth hypersensitivity is mediated by T cells. You see here, okay, mediated by T cells. This is known as the uh, cell-mediated, if you will, hypersensitivity, whereas these is antibody-mediated. And again, T cells are very, very good at killing 2 kinds of cell: virus infected cells, any cells, or virus or cancer cells, if you will. Okay. So we talked about one of the questions was, what are those residential cells that triggers the immune response? They're acting as antigen presenting cell. The correct answer would be dendritic cells. Okay, but other kinds of antigen presenting cells are macrophage, B cells, and reticular endothelial cells. And what all these 4 cells have in common is that they have MSC class 2, which um, are involved in presenting the antigen. Um, and when we talk about lymphocyte, the B cell seems to be there's 2 kinds of lymphocyte. There's B lymphocyte and differentiated B lymphocyte known as plasma. But whereas T lymphocyte, there are different kinds. They're CD4, also known as helper T cells, and CD8, which is cytotoxic T cell, and there are suppressor T cells, and there are regular T cells. Just to note that here, when we talk about cytotoxic T cell, this is one type of lymphocyte, also known as CD8 positive. Okay. Whereas here you see this is also T cell, but this is known as T helper, and this is known as CD4 positive. And CD4 positive helper T cell play a critical role, because you can see here is that humoral immunity, which is, you can think of this as humoral immunity, require helper T cell, or cellular immunity require helper T cell. So the helper T cells play important role is that it help both humoral immunity and cellular immunity. Without these CD4 positive T cells, you don't have antibody production, and you don't have functional cytotoxic T cells, if you will. And this is very critical when we talk about how HIV virus, human immunodeficiency virus, and how those cells infect particularly CD4 positive T cell. And if we can calculate out that CD4 positive T cells within a normal person have roughly about 1,100 CD4 positive T cell. But when your CD4 positive T cells get down to 200 or less than 200 in your, then it's the critical period that you might have a condition known as AIDS, or acquired immunodeficient syndrome, in which their immune system is weak. And those people who have AIDS are prone to have secondary opportunistic infection, things like yeast or Giardiasis, for example. Now, so in addition to B lymphocytes and T lymphocyte, there's another cells known as NK cell. Now, NK cells, as the name implies, they're involved in killing. They're natural killing. What do they kill? Well, again, they kill cancer cells, or they kill viral infected cells. But the NK cell, viral infected cell. Now, NK cells differ from CD8 positive T cells, and that is this right here, NK cell, is non-specific, non-specific. Whereas this right here is very specific. So being very specific is part of the adaptive immunity. So in other words, when these CD8 T cells that kill someone, cells, it only killed a cell that infected with COVID-19 coronavirus, for example. So then if you take the same CD8 positive T cell and see if they're reactive to, say, influenza H1N5, it won't kill it, right? It only very specific to that viral particle of coronavirus, for example. Whereas this one, the NK cells, is that whether the cell is infected with coronavirus or influenza or herpes virus, it's involved in killing any of the virus, any cells that are infected with the virus. Is there a question? Joseph, you have a question?
Yeah, I have a question. Um, you said earlier that macrophages and dendritic cells have something in common.
Yeah, MSC class 2. This is major
MSC class 2.
histocompatibility complex 2. Huh? They're only in antigen presenting cell, APC cell. That was discussed from last week. Listen to the recording. I talked about these cells. Whereas every cells in our body that have a nucleus has another similar called MSC class 1. Okay. So that's the difference between MSC class 1 and MSC class 2. The other thing, if you want to go back here and say, is that the B cell, can recognize the antigen directly. You see here? Whereas the MSC class, whereas the cytotoxic T cell, for example, and helper T cell to some extent, it cannot recognize the antigen directly, right? It only recognizes in the context of the antigen presenting cells. So the antigen presenting cells are these right here who present the antigen, which is little dot here, red dot here, or little red star, to the T cell. So the T cell can only see this particle if it's part of the cell of that antigen presenting cell. Okay. All right, so type of immunoglobulin. So when we talk about humoral immunity, again, the B cells produces this class. There are 5 classes, and I'm going to tell you that the classes are. Now, let me. You see here where it says clonal expansion. Okay. Now, that's what I'm going to talk about. Now, these ideas of clonal expansion. Clonal expansion. What is it? Okay. The other thing that you can compare, if you have to compare between innate immunity and adaptive immunity, and that is you can say, oh, innate immunity is very quick to react. It's there, right? It's like the skin is there. Or inflammation. Once you get an infection, boom, you have inflammation right away. Adaptive immunity, however, takes time. In fact, by the time you get an infection, right, to a point where you get, fully developed adaptive immunity, fully developed immunity. Okay. Now, we just say for this, for example, and that is B cells, right, naive B cells to um, B cells producing um, antibody. Okay, right. So this process in which how you have uh, a fully developed immunity, right? Which here you can think of as naive B cells, uh, is changing, differentiated into a B cells produces the antibody. It takes 2 weeks. Okay, it takes 2 weeks for fully developed immunity. Now, B cell, but it can also start with T cell as well. The fully developed cytotoxic T cell, very specific to a cell that is infected with virus, it takes about 2 weeks, but we just consider here just B cell. Now, and this 2 week is what you see is this process known as clonal expansion occurring. Okay. Okay. It's doing this 2 week is clonal expansion. And what we mean by that is what happened in our body is this: you have a lot of B cells around, and roughly we say it's about 1 million B cells. Okay, they're all B cells, and they're different from each other though, because they have different immunoglobulin on its surface. Okay, now this immunoglobulin on its surface is known as IgD. Okay, of of the 5 immunoglobulin, this one right here is known as the IgD. IgD is also known as, you can think of B cell receptor. Okay. Now these receptors are on the surface of the B cells. Okay. I'm just going to draw one of them, but there's many of them, because every immunoglobulin has two heavy chains. This is one heavy chain. Here's another heavy chain, and this is a light chain, and this is a light chain. The regions that is formed by the heavy chain and a light chain, here's the heavy chain, here's the heavy chain, here's a light chain and a light chain. The pocket that is formed between the heavy and the light chains, this pocket is known as the antigen binding site. I'm just going to write them as AG binding site. Now, I want you to think of these antigen binding site, and every immunoglobulin will have two antigen binding site. There's another one over here as well, okay, ABS, for the antigen binding site. And this pocket is kind of like a lock, right? And that is, every lock has different keys, a different key to fit it. And so with this IgD as a B cell receptor, it has different antigen binding site. So this antibody, for example, can potentially recognize as a circle antigen. This one might recognize as a triangle. This one might recognize a square. This one might recognize as stars, and so forth. Okay. Now, how big is this antigen? Well, roughly in terms of amino acid, somewhere between 9 and 10 amino acid is a nice, can be served as an antigen, can be something that can fit into the pocket, right? And if you think about, there are 20 different 20 different amino acid. So every protein might have a combinations of that. 20 times 20 times 20 times 20 times 20. If you're going to talk about statistically and variability and random, of the arrangement, you can have one antigen could be all alanine, or alanine, all serine, all threonine, or any combination of that. And so you can see that there is tremendous variation within the amino acid. But regardless, right, this substance that is foreign and it's enter your body, right? there should be at least one or two B cell that have the right receptor to recognize it. And so let's say in this case, this one, okay, is the antigen, and this B cell have the right receptor, right, for that. And if that is the case, right, we're saying, okay, there are millions of different B cells, but only this B cell, by the way, B cells that are just have the receptor, but they're not do anything yet, they're young, we call them as naive, okay, we call them as naive B cell, naive B cell. Like being naive is very young, don't innocent, you don't know anything yet. Now there are a million different naive B cells, but if you have one B cell that have the right receptor that bind to the antigen, we're going to cause this B cell to proliferate, right? So you can give it interleukin 2, this is usually macrophage will produce. So then now you have, let's say hypothetically, the receptor is orange, okay? The receptor is orange. Now you're going to cause a B cells that have the same receptor. B cell that has same receptor to expand. And because it's from one B cell, that's what we mean by clonal. Clonal expansion means we're just going to pick that one person and make it more, because the rest of the B cell is no good to us. The B cell that have the right receptor is good, because that's the one that combines to the antigen, okay? And that's the one that we should cause it to stimulate it to proliferate, to make more of them, so we can have the more proper B cells involved in killing the antigen. So keep in mind that. So that's what we mean by clonal expansion, is that we going to pick one of the B cells that have the right receptor and expand it or cause it to proliferate. And when we talk about immunoglobulin, then the IgD is the one type that is found on a B cell that acts as B cell receptor. There you go. So that's the one type of immunoglobulin. IgA is usually occur as a dimer. So a dimer is like this. So here's one immunoglobulin, and it sticks together to this linker, and here's another immunoglobulin. So if you want to say that, oh, IgA then would have 4 antigen binding site. Okay, so you have one here, one here, one here, and one here. Now, IgA is typically secreted in mucosal membrane. In the mucosal membrane. So your respiratory tract, your GI tract, and to some extent, part of the mammary gland, which is also have this ductal system that produces the milk. And so when the child feed on this, suckle on the nipples, in receiving the milk, the child is also getting protective immunity through IgA. But usually when your respiratory tract produces the antibody, is this type, is the IgA type. And so, your gastrointestinal tract, if you get diarrhea, that kind of thing, the IgA is being produced. Okay. Any questions so far? Okay. The immunoglobulin that is first to be made is this one right here. It's called IgM. IgM is first to made, and IgM acting as a pentamer, okay, which have 5 immunoglobulin that stick together like this. And so IgM then would have 10 antigen binding sites. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Now, if this happens to be, say, red blood cell, this is a red blood cell, the immunoglobulin okay, from IgM can agglutinate all of the red blood cells. So IgM is the mediator. Let me write this down. IgM is the first antibody is made, and it is a mediator of mismatch reaction. What mismatch reaction is that if your blood type is A and you happen to have a B blood, so you already have preformed anti-B antibody, and so if you have the B antibody, you're going to see this agglutination in which antibody and the red blood cell will agglutinate, and then these clumps get clogged in small blood vessel. You can create ischemia or downstream from that crisis, agglutinations occur. That's IgM. Okay, it's a good thing to know. Mismatch reaction. Alrighty, IgG is the most abundant immunoglobulin, and it's the only one that can crosses the placenta. Right? In hemolytic disease of the newborn, or erythroblastosis fetalis, we just call it Rh incompatibility, in which the Rh mother carrying Rh positive child during a second pregnancy, the antibody that is involved in destroying the fetus is IgG. Okay, so that's a lot. I'm going to write this down. It is the most abundant immunoglobulin, immunoglobulin. It is a mediator of hemolytic disease of the newborn. So you can see that hemolytic means lysis of the red blood cell. Okay, hemolytic disease of newborn is also known erythroblastosis fetalis, okay, which is often seen in Rh negative mother during her second pregnancy, carrying the same Rh positive fetus. Okay. Now, it's in general, and Ig, the one, let me write this down. IgG is the only antibody that can cross the placenta. Okay. Now, typically, second pregnancy is because an Rh negative mother carrying an Rh positive child during the first pregnancy, okay, where does the child get the Rh factor from? Well, the father has to be Rh positive. Well, if the father is Rh negative and her child is Rh negative, well, I don't think that is the father. That he could take the responsibility for the next 18 years, but he's not the father. He's not the real father. You know, she's just a gold digger, for example. So the child who is Rh positive must get it from the father who is Rh positive, but she herself is Rh negative. Now, if you female who is an Rh negative, you don't have to worry. Only if you are Rh negative. And after the first pregnancy, there's a change of blood, and then the Rh positive factor is exposed. So then she produces the antibody, and then during the subsequent pregnancy, then the antibody that is preformed can cross the placenta and destroy that. This is known as hemolytic disease of the newborn. Monophilia. Monophia. Ms. Brown, do you have a question? Okay, so you don't have a question. I'm going to continue. Okay. IgE is the only antibody that is involved in, I would say directly involved in, IgE is involved in allergic reaction. Okay, so typically an antibody, again, has, yes, so you can listen to a recording if your computer is acting up. Here's a heavy change. Here's a heavy change of an antibody. Here's a light change. Here's a light change. This is the antigen binding site. Okay, some people say, oh, it's an antigen binding pocket. That's a fine. You got the idea. Okay. But this right here of an antibody known as the fragment of constant or FC region. Now, you know, you can have, you know, a hundreds and thousands of immunoglobulin, okay, and they all will have the same constant, you know, heavy constant. We call this the gamma change, you will. The only different with one immunoglobulin might be different with each other at this antigen binding site, but this right here is all the same, okay? And in fact, the immunoglobulin might be different. It's because of different FC region. Uh, F, if you want to know IgE, the heavy chain is epsilon. IgD, the heavy chain would be delta. The immunoglobulin IgM, the heavy chain is mu. The heavy chain for the immunoglobulin A is alpha, and the immunoglobulin, the heavy chain for immunoglobulin IgG is gamma. Okay, this is the Greek letter indicating different regions of the gene. You don't need to know that. What you need to know is this. This is the FC fragment. And I'm only going to show you this in the context of, say, a mast cell, for example. The mast cell and the, which is the same thing as basophil. These are two that is very similar cells. And what they do is they have IgE immunoglobulin. They have, I'm just going to draw it like this. Let's call it FC receptor. Okay. FC receptor meaning that it will bind to an antibody like this. And it binds, this FC receptor is usually to the antibody IgE, for example. But if the antibody here doesn't have any antigen to it, it won't bind. But if there's an antigen binds to it, then the antigen antibody complex with IgE like this will bind to the FC. And in doing so, it's going to cause these granules to come forward that leads to degranulation, if you will. And degranulation of this, degranulation will lead to, let's say, release of histamine, which leads to vasodilation, if you will. So IgE, particularly the FC regions of IgE, when it binds to like a pollen or something, the antibody antigen complex binds to the FC receptor on the surface of the mast cell, leads to degranulation. Okay. Okay, so proteins, this is a gel electrophoresis, which is basically a matrix. And this matrix is actually used to separate proteins based on the size. If the size is small, it's going to travel faster than the size that is large. All right. And we use this gel to separate DNA, if you will. Typically, one would not show us like this. You would do it reverse, but it doesn't matter. This is where they originally load all the protein over here. Okay. Now, if you subject this to current from negative to positive charge, right, you're going to separate proteins based on the size. The smallest protein, which is here, is going to migrate the fastest, which is further away from where you originally load them. Okay. And you can see albumin is small, it will travel the further, right? Then you have different immunoglobulin, IgA, which is the alpha globe, there are other proteins in your body, which is, in the future, for example, if I ask you, what are the three major proteins in your blood? The three major proteins are albumin, okay, globulin is just a simple term. Globulins has two kinds. They're alpha, beta, and gamma. And then the third proteins are fibrinogen. Fibrinogen. So here are the three major proteins that in your blood, and we'll come back to talk about this when we talk about blood disorder. But you can see globulin alpha beta, which is these right here, alpha and beta, they're much smaller, okay, because they travel further away from where you originally load them. But these alpha and beta are usually involved in carrying lipids. So these are also known as low lipoprotein. The gamma globulin, which is this, gamma globulin is antibody. Okay? Is antibody. And the reason why you see a smear, in a normal person, and that is, this indicate the different sizes of the immunoglobulin. Some of them might be heavier than the other one, it's lower. There is, however, some patient that only produce one type of antibody. Now, you only see this is in a cancer patient, particular a patient who has multiple myeloma disease, multiple myeloma disease, which is cancer of the plasma cell. Okay. Plasma cell is very similar to B cell. They're also known as differentiated B cell or antibody producing cells. And you can see in this individual, what happened is that there are so many plasma cells, and they're differentiated now. It considered as clonal, right? It's like one type of B cell now, whereas this property that you see, a smear, is produced by many different types of B cells, right? Many different clones. Where here it's just one clone, and it produces so much. This is known as monoclonal protein, also known as M proteins. Because there's so much in the blood, the protein get filters to the urinary system, and it's going to end up as in the urine, if you will. And so in the future, if you say, oh, a patient, and you detected the M proteins in the urines of the patient, that suggests the person had multiple myeloma. Okay, so you can do, there's another way to detect it through this different peak in chromatography or through this gel, as you can see. Okay, now, one of the most important things to talk about, and that is in the adaptive immunity, it takes 2 weeks to develop maximally, right? So if you guys, I don't know how many of you have got the vaccine for the coronavirus. If you have taken, so right now there are 2 available, but future one is maybe AstraZeneca available, but the 2 available ones for most of New York City healthcare vaccinator or even educator like myself, the Pfizer vaccine and the Moderna vaccine. This is all mRNA type based vaccine. And if you take the Pfizer, it's recommended that you get your first dose, and 3 weeks later, you get the second dose known as booster. For the Moderna, you take your first dose, 4 weeks later, you get your booster 4 weeks later to get your second dose. And this is fall within this context, and that is when you give the person the vaccine, which is an antigen, if you will, adaptive immunity will come in, right? And you don't want to give the booster right away. You want to wait. What is minimum time to wait? It should be at least 2 weeks. Pfizer recommended 3. Moderna recommended 4. Sometime, there's now the studies that, well, if you delay in the second dose, then you get a stronger immune response. Okay. Now, if you follow this blue curve and green curve, you can see here. Now, if you look at the antibody level in the blood versus time. Now, let's say, for example, your first exposure right here, okay, time 0. The first antibody that you come and see, which is IgM, okay? And this is quick. It could be a week, but IgM is not stay on for that long. IgM is not considered as protective immunity at all. What you want, if you want to give the immunity that is protect you against the pathogen, we call that protective immunity. You have to wait for 2 weeks. So right about here, okay, you can say right here is peak is 2 weeks. And what you see is that the protective immunity is involving with IgG type, okay, IgG. And then it goes down. And this could be years later, right? Or 3 weeks later, or 2 weeks minimum later, right? After you have this, you can give the second exposure, okay, re-exposure, and you can see how you have a titer is really high, okay? This is known as a booster, if you will, right? That's why you want to give a second dose so you get much higher titer. But even if with the first dose, your body now is protected somewhat to coronavirus. Some people think that if you have your first vaccine with coronavirus, you get 50% protective immunity. Okay, but what does that mean? That meaning that if or should you come in contact with the actual coronavirus, right? The COVID-19, your body is ready to mount an immune response. Very robust, right? And thus they say, well, if you get vaccinated one shot, this right here will give you some protection. And it's reported that people have just only one dose might have fewer sign and symptom related to if they have, they might not have severe fever, they might not have as much respiratory problem. There's other people that suggest that even with first vaccination, they are not contagious as you would without this. So the take-home message is this: IgM is the first antibody is made. IgG is second wave of antibodies made. And then the other important thing, and that is if you re-expose this to the same antigen, you get a second robust immune response. And the protective immunity is IgG, not IgM, right? But this is in the context that I want you to think of as well. And this, the question might be is, now someone, let's say a patient comes into the clinic, has who complaining of abdominal pain. And if you palpate it, you think that person may have an enlarged liver, call it splenomegaly, enlarged liver. You think that there might be this person is, by the way, is intravenous drug user, IVD. Okay, so it could be suggested that it's a Hep C viral infection. But you always wonder, is this person who have yeah? Someone have a question? Someone have a question? No question? So someone who's in the clinic with Hep C or hepatitis viral infection, right? You don't know, is it maybe, is it an acute infection or a reactivation of a chronic infection? Okay. So you gotta find out, is this, this is the person who has recently contracted the Hep C, or is it this person have had Hep C viral infection and maybe ingesting some kind of toxin, aflatoxin, that causes the virus to reactivate. You don't know, right? So what do you do? How do you differentiate this? Well, you follow up. Is IgM against Hep C present? Okay. And what's the answer? And what about IgG? Okay. So if I tell you that this person do not have IgM against Hep C, only have IgG against Hep C, what does that tell you?
It's chronic.
Chronic, yeah. And if I say, oh, there's an IgM present against Hep C, so what do you think? Is it chronic? IgM? Chronic?
Good.
No. IgG is chronic, but IgM,
Right.
that means recently contracted.
Yeah, so IgM goes up would mean that it's an acute infection.
Yes, it's acute infection. So we're going back to that same graph, that IgM is the first antibody produced, and then you get your IgG afterwards. So that's one way to differentiate the difference between the presence of IgM versus IgG. So keep that in mind. Maybe I throw in a question next week. Okay. go a couple more slides, and then we'll take our 5-minute break. Okay, so again, there are some feature of an antibody that you need to know. This portion right here is known FAB, or fragment of antibody. We talk about FC fragment, which is this. This right here is the heavy change, 2 heavy change here, and 2 light change. The antigen binding site or antigen binding pocket would be this, is where different amino acids in this variable regions, or sometimes within there it's called hypervariable region. So if you look at IgG and hundreds of different IgG, the FC might be the same, but this one area that just the amino acid keeps changing, thus it forms different pockets. So A5 is antigen binding site. And this is the hinge region, or FC. And there's a disulfide bonding between the heavy and the light change here, and then disulfide bonding, 2 of them between the heavy change. You don't need to know the disulfide binding, but note what the hinge region is. So in other words, 1, 2, 3, 4, 5, 6 antibody, different regions of antibody you need to know. Okay, and perhaps over here, there is also known as the complement binding site. And typically, the antibodies without the antigen, you cannot see the complement binding site. But once the antigen binds to the antigen, this site sort of like reveal, okay? And so the complement can then be binding to it. This is known as the complement binding site. In the blood, there are a number of complement binding or complement proteins, if you will. They'll like these will have names like C1, C2, C3, C4, C5, C6, C7, C8, C9, C1, C2, C3, that kind of complement protein, particularly C1, will bind to this right here. Hence the name. Okay. Now we talked about different kinds of T lymphocyte already. There's cytotoxic T lymphocyte effector, also known as CD8. Remember that? Okay, CD8 positive T cells. There are helper T cells, which help both B cells and T cells. We already talked about that. This is known as CD4 positive. Suppressor T cell, also known as regulatory T cells or Treg, and then memory T cells, Tmem. Now this is the Treg is very important. This is I wrote a review on this cell. It's called regulatory T cell. One of the functions of the regulatory T cell is maybe involved in anti-inflammation, for example. Okay, which basically is regulating, hence the name. They're regulating the immune system, and so when you have an infection, right, the immune system will come in and try to resolve it. But after you resolve the infection, the insult, right, you want the inflammatory response to go away. You don't want it to have it continue going. If it's continue going, is chronic infection, right? And the cells that is make sure that the inflammatory goes down, right, to normal process, is known as regulatory T cell. So if you say, well, what happened if you have a dysfunctional regulatory T cell? A dysfunctional regulatory T cell is one of the conditions that might lead to chronic inflammation, if you will. Okay? There are many causes of chronic inflammation, but I'm saying if you don't have a way to involve in anti-inflammatory response, you're going to have a continued anti-inflammatory response. Another important thing is that there are this right here may be involved in surveillance. Okay? surveillance. The word surveillance meaning there are um, cells that sort of like go around, make sure that everyone's doing its job and its normal function, right? And Treg or suppressor T cell may be involved in uh, preventing um, preventing cytotoxic T cell from killing every cells in your body, right? What if you have a dysregulations of cytotoxic T cell? If you have a dysregulations of cytotoxic T cells, so let's say, for example, cytotoxic T cells is killing your own normal cells. Okay. If this is the case, this is known autoimmune, and what prevent this is Treg. Okay. So Treg is preventing the cytotoxic T cell from go full, full metal on these cells, right? So what happens if you have a dysfunctions of regular T cell? If you have dysfunctional regular T cell, these cytotoxic T cell can start attacking these cells, okay? So this is one of the 4 conditions that could lead to autoimmune disease, okay? So dysfunction of the Treg cell can lead to autoimmune disease. This is one of the 4 hypotheses that causes autoimmune disease. Okay. Okay, so hypersensitivity. Let's do 10 more minutes and take a break. There are 4 different hypersensitivity, type 1, type 2, type 3, type 4. I would say these 3 are mediated by antibodies. This is mediated by T cells. The fastest is this one, immediate one, okay? And usually this is involved in like allergy, like peanut allergy or shellfish allergy or venom, allergy that immediately could lead to shock, for example, volumetric shock, low volume shock. Type 2 hypersensitivity, cytotoxic hypersensitive. This is generally more related to autoimmune disease, okay, where autoimmune disease where antibody is attacking self-antigen. And there are many of them. I'm just going to list a couple of them here. Since we talk about it already, yeah, I think I should talk about this one. It's known as rheumatic fever. Okay. Now, rheumatic fever I can discuss in 2 contexts. Rheumatic fever is a disease in which the antibody is binding and damaging the antigen in the mitral valve. Okay, that's what rheumatic fever is. Rheumatic fever is when you have a condition in which the antibody is binding to the antigens on the surface of the mitral valve. Over time could damage it, leads to valvular insufficiency, and sequela of that is enlarged left ventricle wall, because that is a structural damage that could lead to functional damage, and that is lower stroke volume, blood pressure will drop, if you will. Now, this is the second um, um, hypothesis that could be considered uh, causing autoimmune disease, if you will. Okay, and this is known as the second. I'm gonna write this down. This is the second hypothesis of autoimmune disease, which we define them as molecular mimicry. Okay. What is molecular mimicry? Well, molecular mean antibodies, DNA, that's molecular. Mimicry means similar, and so the cause, now we know what rheumatic fever is. Usually a patient, a child, right, might have a strep infection and in the throat. You're going to have antibody that produced against the strep infection. So it turns out that antibody now reacted to self-antigen, which is on the mitral valve. You see here, okay? So that's rheumatic fever. But there are many diseases in which in an antibody that is meant to react to a pathogen, it end up being attacking the self-antigen. And that's because we share the same molecular molecule, the same sequence of amino acid. So the sequence of amino acid that you find in the mitral valve, it happens to be found in the strep infection. So many people think that you have other autoimmune disease. What really triggers it is probably some infectious particle. Okay, so that's the second causes of molecular mimicry, and if you define, and that is the antibody binding to self-antigen, then it is type 2 immunoglobulin, type 2 hypersensitivity. Okay. And then the third type of hypersensitivity is known as the antigen antibody complex. And so the problem is that when you have an antigen and antibody complex, so an antigen and antibody complex in the blood, and they start circulating, okay? And this ultimately what goes to the kidney have to filter it, but it can't filter. It gets stuck in the glomerulus, okay? That where the antigen antibody complex, sequela could be due to, leads to glomerular nephritis. Okay, which means there's a inflammatory response in the nephrons or the glomerulus, if you will. But the antigen antibody complex can also get lodged in the respiratory membranes in the lung, for example, can lead to Farmer's disease, if you will, interfere with gases exchange. So whenever you have an antigen antibody complex, think of it as type 3 hypersensitivity. And this is very common in the case of lupus patient. Okay, and lupus is it is an autoimmune disease in which antibody is binding to double-stranded DNA, and it's that antigen antibody complex usually circulating goes to the kidney and can lead to glomerular nephritis, if you will, right? So let's finish up with this different types of hypersensitivity, and then we'll take a break, and then we'll talk a 5-minute break. Okay, so this immunoglobulin should be quickly, as I explained to you, already. Type 1, very quick to react, is mediated by um, antibody. Okay, and here it just shows you that that foreign substance. Type 1 is usually mediated things like pollens or dust that can also mediate. And in general, is known as atopy. Okay, produces the antibody. Antibodies could lead to particularly this is known as IgE. You can see here how IgE by itself is binding to the Fc receptor of the mast cell, causes the degranulations of the things like histamine, can lead to vasodilation. Uh, Actually, the same molecule can also lead to bronchoconstriction. So, people have this kind of allergic reaction. Typically, after bronchial is constricted, so it's harder to breathe. And to overcome this, when someone has an allergy, what you want to do is you want to carry around an EpiPen, epinephrine, and we'll later going to find out that epinephrine is catecholamine, and what it is the major vasoconstrictor, okay, and bronchodilator. It's the vasoconstrictor and bronchodilator. And so what this does is that if someone has an allergic reaction, we call it anaphylactic shock. You give them injections of the epinephrine, the blood vessel to constrict, blood pressure will be bounce up, because if you have major vasodilation, the blood pressure will drop. The airway, and due to anaphylactic shock, the airway might be constricted. It's hard for a person to breathe. Having a bronchodilator will help breathing, if you will. Okay. Type 2 hypersensitivity is the antibody binding to the self-antigen. In this case, there's another condition known as myasthenia gravis. Okay. Myasthenia gravis, in which the antibody is attacking the acetylcholine receptor. Okay, so the antibody binds to the acetylcholine receptor, and doing so, this is a very grave situation. It's because the motor neuron usually release acetylcholine, causes the contraction of the diaphragm in the case of breathing, if you will. Now, if it's attacking the acetylcholine receptor, then you cannot innervate the diaphragm, then the person can't breathe, if you will. That's the ultimate problem with this myasthenia gravis. Here it says myasthenia gravis, neuromuscular junction. Here's this acetylcholine receptor and how the antibody is attacking it. Okay. What causes this? The B cells produces it. We still don't know yet. It might be molecular mimicry. It might be dysregulations of the immune of regulatory T cells, or I'm going to cause this is the third. You can cause this in general. The third causes of autoimmune disease. I'll write this down. Or let's say third hypothesis. the autoimmune disease is the unmasking of self. Okay, the third hypothesis of autoimmune disease is no unmasking of self-antigen. It may not relate it to myasthenia gravis. We don't know. Okay, we don't know. That's the point here. The point here with the unmasking is that there are some site in our body that is privileged. Okay, in other words, the placenta is considered as a privileged site, or anywhere in our body that does not have blood cannot flow to it, right? If blood cannot flow, there's no B cells or T cell immune cell flow to it. And so they're sitting normally there, right? And this might be related to the male sperm, if you will. It's the sperm is made in the seminiferous tubule, and the Sertoli cells have these, we call it the testes blood barrier, and then they form a tight junction to prevent the sperm from exposure to the blood. Now, if, however, there's a damage through the gonads, or someone might hit someone in the eye, now the antigen is exposed to the blood. Then you can trigger the immune response. And then the antibodies started to go on and attacking the self-antigen. If it's normal condition, you cannot see it. But once it's exposed, perhaps, the blood never reaches the antigen, never reaches the acetylcholine receptor. Somehow the acetylcholine receptor is exposed to the blood. Now the antibodies is produced against this, leads to myasthenia gravis. But in general, we call that it is the unmasking of the self-antigen, right? So now you know at least three: molecular mimicry, unmasking the self-antigen, and dysregulations of regulatory T cells. All right, and then the fourth hypothesis I'm going to write here is known as the fourth hypothesis is known as the failure of tolerance. Failures of tolerance. I'll come back to this later, but to make the story complete, now you know the four hypotheses. And this is due to tolerance, means you are trained the T cells in the thymus to tell the T cell that if you see the self-antigen, ignore it. This is known as tolerance, right? So somehow that T cell sees the antigen and it's supposed to ignore it, but reacting to it. And so it doesn't have the proper training, if you will. So that's what we call it, failures of tolerance. Let's finish up this hypersensitivity. The third type is known as type 3, where you have the antigen-antibody complex, and the antigen-antibody complex can travels in the blood, and it goes to and damage the kidney, or in this case, the antigen-antibody complex large into the lungs. This would be considered as a vellus, and could damage or interfere with the respiratory membrane. This is known as Farmer's disease, if you will. Okay. And the antigen-antibody complex can not only have local effect, but systemic effect. And that is, this can go everywhere, perhaps damage a small blood vessel as well. And then the fourth, hypersensitivity. This is require the whole cell. You see here, require the whole cells, and is known as cell-mediated immunity or cell-mediated hypersensitivity. And this is usually take a long time. So this is also known as the delayed type hypersensitivity. Okay, delay, tight, hypersensitivity. And I'll give you two examples. Sensitivity. Two examples are PPD, and poison oak. Okay, so in the case of poison oak, what happened is that if you go camping and you brush against the um, compound that he finds in the leaf, it reacted with your self antigen and on the weekend, but you probably don't get a severe allergic reaction until Monday or Tuesday, and that is delay, and that usually causes cytotoxic T cell. Another T cells that is meeting that. The other example is PPD, right? In the U.S., we usually do not vaccinate people with BCG. And BCG stands for Bacillus of Calmette and Guerin. Okay. It's two French Calmette and Guerin. It's two French scientists who developed this. It's actually is a organism known as Mycobacterium bovis, or it derived from Mycobacterium bovis. Mycobacterium, I should write it properly. Mycobacterium bovis. Mycobacterium is a microorganism that usually infect cow. It doesn't really hurt a human. What hurts human is Mycobacterium tuberculosis. Mycobacterium tuberculosis, right? Which is caused tuberculosis, or also known as TB. Okay. And it find out that in the early 19th century, 1900 or 20th century, many people die from tuberculosis. Okay, if you're infected, you coughed up, people didn't know, you inhale that, then you get TB. And TB is also known as consumption disease. People have it. There's slowly granulomas develop. TB, I think now you should know, is acid fast associated with that. And what kind of necrosis? Caseous necrosis, as you will. And when Calmette and Guerin comes up with this vaccine, you give it to people BCG, they seem to be protected against TB so they don't get sick, for example. And BCG, to some extent, have been used in a third world country a lot to curb the tuberculosis infection, because TB is not a predominant disease, or doesn't really have prevalence is not that high in the U.S. We don't vaccinate our children with BCG, but if you do vaccinate with your child with BCG, myself, who has come from Vietnam, vaccinated early with BCG, if I do the PPD test, I'm going to be positive. And what is PPD test? Is that they put the antigen, this is PPD stands for purifies protein derivative, which is actually isolated from Mycobacterium. They put it in your skin, right? And they don't measure it right away. You wait it 2 or 3 days later. If you have a prior exposure, you're going to get reactions to it, and you measure it, right? In the U.S., you put PPD there should be no reactions at all 2 or 3 days later. But if it's positive, then you have to be worried. One, the person recently got infected with TB, or this person has BCG in the past. So I always have to tell the people is that, hey, you need to do a PPD test. I'm going to be positive because I know I had the vaccine. So all the kids, all you guys come from the Caribbean, they infected you guys with, well, vaccinate you, BCG, you PPD positive. Now, you know, the one could argue is why not just give the children BCG in the U.S. So to get them have protection anyway? Well, there's always risk versus benefit, and there is not much benefit to getting the BCG in the U.S. But what happened is that if you vaccinate the children with BCG, then in essence you're taking the PPD test away. You can't do that test anymore. So they hold off on that, and so that you're kind of like clean. You go to Caribbean, right? And you come back, you do the PPD test, boom, you're positive, and say, oh, you got infected in Caribbean, right? Maybe St. Martin or something. I don't know. Maybe Jamaica. I don't know. Sorry, someone have a question? Any questions? Comment?
No, Professor, I was just saying that usually happens to me too. I got vaccinated in
Right.
Ecuador.
In Ecuador? Okay, good.
Yes, and then
Yeah.
when I will go and get the test, it feels like I got exposed, and then I have to go and take an extra
Yeah,
test.
good. They're good to know because they would say, "Oh, boom, you're PPD positive, quarantine you. We got to give you isoniazid, ethambutol for the 3 months." It's not necessary, right? Why do you give you these anti-tuberculosis drugs when you don't need it? Good, so you know that. Just tell them that, hey, I'm already vaccinated for BCG. Great. Okay, are there any other questions? Okay, why don't we take 5-minute break, please? And then I'll try to come back and finish with the rest of the discussion. Next week, exam 3.